Welcome to the Depo Medrol carpal tunnel injection demonstration. This presentation provides some general guidelines for administering Depo Medrol in the treatment of carpal tunnel syndrome. When treating carpal tunnel syndrome with Depo Medrol, the goals are to enter the wrist with as little pain as possible and to inject Depo Medrol into the carpal tunnel without injuring nearby neuromuscular bundles or introducing infection. The carpal tunnel is formed by the carpal bones dorsally and the transverse carpal ligament ventrally. Within the carpal tunnel are the median nerve and the flexor tendons of the hand. During the injection procedure, it is important to stay on the ulnar side of the palmaris tendon. This will avoid damage to the median nerve. Also, be careful to stay to the radial side of the flexor carpi ulnaris tendon to avoid damaging the ulnar nerve. From this angle, it is more fully apparent how the carpal tunnel is formed by the carpal bones and the transverse carpal ligament. Identifying the optimal injection site requires a careful review of the patient's wrist. For orientation purposes, the course of the palmaris longus tendon is marked. The correct injection site is next to the palmaris longus tendon, about 1 centimeter proximal to the wrist crease. First, cleanse the skin with antiseptic. Then, using 1% anesthetic, anesthetize the skin. Ask the patient to inform you if there is a burning sensation or electric shocks felt down into the hand during the injection procedure. Using a local anesthetic in conjunction with Depo Medrol is elective. Local anesthesia can help minimize patient discomfort. Note, however, that Depo Medrol should not be mixed or diluted with other solutions due to potential physical incompatibilities, as described in the product labeling. Therefore, if you use an anesthetic agent, inject it before administering Depo Medrol. Always read the anesthetics package insert carefully and observe all recommended precautions. With a 3/4 inch 25 gauge needle, inject the canal at the ulnar side of the palmaris longus and to the radial side of the flexor carpi ulnaris. Angle the needle at about 30 to 45 degrees, going up toward the hand. If resistance is encountered, or if the patient experiences paresthesia, the needle should be withdrawn and redirected in a more ulnar fashion. If the patient does not feel a burning sensation or electric shock, advance the needle into the carpal tunnel. Here, the needle has correctly entered the wrist and has been directed toward the ring finger. Once the needle is properly inserted and the anesthetic has been injected, replace the syringe with a new one containing the proper dose of Depo Medrol. The appropriate dose of Depo Medrol for the treatment of conditions involving tendinous and bursal structures varies with the condition being treated and ranges from 4 milligrams to 30 milligrams. With the syringe containing the Depo Medrol in place, use steady pressure to slowly inject Depo Medrol directly into the carpal tunnel. Apply a sterile dressing at the needle puncture site and ask the patient to open and close their fingers several times. Advise the patient of any post-injection care techniques you recommend, such as the use of ice packs and over-the-counter medicines. Also, inform the patient of the possibility of a post-injection flare. Such post-injection steroid flare may cause a worsening of symptoms during the first 24 to 48 hours following injection. As with all corticosteroids, side effects may occur with Depo Medrol, including post-injection steroid flare, tendon rupture, and crystal-induced synovitis, as well as hyperglycemia, osteoporosis, psychiatric disorders, myopathy, and growth arrest.